Okay, so it is 1 o'clock, so we will begin the session. Welcome everyone to this Lunch and Learn brought to you today by Boost and the Knowledge and Library Service from North Cumbria Integrated Care. I'm especially pleased to welcome Hamdi Hamzah, who is going to talk to us today about the lessons learned from Mobilising WorkWell and practical lessons for strategic commissioning. If we can move on to the next slide, just to give you a little overview, these lunch and learn sessions are a space for health and care staff to come together, to share any experiences, to learn something new relating to health and care, with a focus on quality improvement, and of course to be signposted to any further resources that you will find useful. The next slide, I'm going to run down a few protocols for the session. This is going to be recorded, so we ask that webcams are off initially while the presentation takes place. Feel free to pop your webcam on at the end if you want to contribute or ask a question. Please make sure that you're muted while the presentation takes place, just to avoid any distractions. You can use the chat box to pop any questions in there or any contributions or comments. If we have time at the end of the session, we will come back to the chat for any questions that have been raised. If not, we will try and get back to these questions and give you an answer after the event. Please do listen with respect and be present, and teach this forward. Share this with your colleagues, your wider networks, and you will be sent the recording link at the end of following the session. So again, feel free to share that far and wide. And so without further ado, I will hand over to Hamdi.
Thanks, Tracy. Hi, everyone. Good afternoon. Such a pleasure to sort of share some of the learning that we gained from Mobilising WorkWell. My name is Hamdi Hamzah. I'm a Research and Evaluation Officer as part of the Research and Evaluation team in the ICB. And we've been given the opportunity to be embedded in the sort of WorkWell Health and Growth Accelerator space, or now Work and Health space, that sort of looks at economic inactivity and how do we sort of tackle that from an NHS perspective. So today's presentation will be learning from the approach that we took to capture sort of the pain points of mobilizing such a big, massive sort of priority in the ICB, and the sort of research approach that comes with it. Before diving into too much into what was done, I suppose it's just good to set the scene a bit, and what's economic inactivity, and I suppose the definitions on the slide there. But I do think one of the key sort of takeaways from knowing about economic inactivity is that most 34% of those who are economically inactive are due to long-term sickness. And that's in the northeastern of Cumbria compared to 28% in England. So the rates that we are seeing in our region are higher, and the main reasons are due to mental health and MSK issues, which is where I suppose the NHS contribution to the economic inactivity space comes into play. Within our region, and I say our region, these are stats for the northeast, but I do have the figures for North Cumbria, where Cumberland is at 20.5% and Westmoreland and Furness is at 17.6%. I guess overall we can clearly see that the areas in the northeast and North Cumbria area mainly are all above the England average, except for Westmoreland and Furness. But that's probably why there is a need for a program that tackles health-related economic inactivity, because there's a need for it in our region. The WorkWell program, the overall aim is to help people stay well and stay working, based on a Health and Growth Accelerator funding given in 25-26. And fortunately, we've been given more funding from the Health and Growth Accelerator as well as the WorkWell funding stream, so sort of pulling different resources to try and address economic inactivity in our region. And with this program comes 3 pillars. The first being a WorkWell service, looking at having work coaches in different community and primary care settings, and offering a biopsychosocial support to different individuals who might feel that work related stress or issues are impacting how they remain in work. So there's a prevention angle to the piece of work, and looking at how do we do that quite early doors rather than when people are already on not working and they're already economically inactive. The second pillar tackles sort of supports the NHS and care staff in terms of their well-being, and there's investment in the regional staff well-being hub that CNTW are doing, and recently won an award as well. And based on some of the evaluation that we've done, quite positive outcomes from there as well. The third pillar looks at the healthier workplaces, supporting SMEs, and what else can be done to encourage employers to think about getting people well and working as well. Because some of the insights that we've gained as well mentioned some of that prevention bit might come from employers. So this is an overview of what WorkWell is. And with this, it's a massive piece of work in the ICB. There's a lot happening. There's a lot of considerations that need to be put in place. And I suppose when we were thinking around evidence and evaluation, we put in place an evaluation framework to just give us a sort of guide or an idea of what the considerations are when we think about what evidence we need to generate in this space. And this presentation won't cover all of it, but I suppose it's just giving a flavor and taste of the complexities and some of the considerations that needed to come into place, so that we think about how do we best generate the evidence needed for different commissioning decisions, different sort of outcomes within this space. But for this presentation, it's focusing on the centerpiece on implementation learning and sharing some of those insights here. I suppose the aims of this piece of work is to, as I said earlier, it's about learning what can we learn from commissioners when they commissioned WorkWell services as part of the health and growth funding, and thinking about how can we be better positioned as a strategic commissioner in the future, because there's a lot of learning in terms of what's happening in some of the different meetings. And I think just to sort of put things into context, the value, I suppose, of having the research and evaluation team in this program of work is that being part of some of the meetings that happen in terms of mobilizing the services. And from June to September 25 alone, there were more than 300 hours spent shared across 20 professionals to mobilize the program. So there's a lot of discussions, a lot of considerations, a lot of tensions as well. So how do we then capture that in a more systematic way and think about, is there a qualitative sort of research approach that can be employed so that the learning doesn't just stay within that space, and we take that learning and then feed that back to sort of different groups, different governance structures as well, and so that we ensure that knowledge mobilization component happens seamlessly throughout different considerations, different programs of work. And these meetings are attended by different professionals, such as at the time it was the local delivery teams, now known as the neighborhood health teams, and there were 6 of them at the time. And then there were colleagues from procurement, finance, and how do we capture that insights from different stakeholders and bring that back into the evidence that we need to generate. And at the same time, it was a high priority, and the national team wanted some evidence already, even though there was everything's being mobilized at the pace that it was at the time. So there was that pressure to know what can we learn at that moment before we start seeing sort of the impact data that comes with such a large program. So as part of this analysis, there's 2 parts to it. So the first is looking at sort of the weekly neighborhood health team work and health teams transcripts. So there's a standing meeting that happens on every Wednesday, and this is where a lot of the discussions around what's working, what's not working, how can each team be supported more, and they are recorded. So in a way, it was an opportunity really for people to, while they were using it to catch up on meetings they missed, but there were transcripts from there. And from putting my researcher hat on here, really is that thinking about, is that an untapped data source that we can look at in terms of analyzing sort of impact, sort of that learning a bit more in depth, and see if there are anything that we can capture a bit more systematically. So for the first analysis, there was around 9 hours of recording, and that sort of gave a flavor of what learning that we can capture. The second part involves interviews or focus groups with colleagues across the 6 teams at the time, and part of the reason that the second part came into play was because I presented findings for the first part at a qualitative symposium at Newcastle University, and one of the questions I got was, how do we know that people are being authentic in their responses and sharing what they're actually concerned about, and how do we ensure that that's that sort of in-depth understanding of what's actually happening, something that only interviews or focus groups could potentially uncover and could potentially sort of bring to light a bit further, because some of these meetings can be quite formal and structured, and not everyone might be comfortable sharing their thoughts. My response to that was, being part of these meetings was actually, it did feel like it was a space that if people weren't happy, they will just share within the group that they're not, that some of the concerns, some of the issues, and it's quite a space that people are quite comfortable sharing their views on. But again, the researcher in me, I suppose, is just not wanting to take that assumption for granted and thinking around, are we missing anything from the first analysis? So that's probably why we did the second part. On the slide, you can see the key lines of inquiry. Essentially, I think it's just reiterating some of the questions that was mentioned earlier on in terms of the aim, what can we learn, what helped commissioning, what are the challenges, and what could be improved. So the first part, I think some of the enablers that we found it involved the GP engagement side of things. So the program had a local enhanced scheme where GPs were incentivized to refer patients into the program. There was also webinars and sort of flexible sign-up deadlines to support engagement. Whether or not the less is effective, that's probably a conversation for a different sort of piece of work. But I think at the start of the program, where it allowed practices to be informed of what was happening, how they could be involved. It was probably a sort of enabler that the local teams felt needed to be in place so that they could start that conversation and allow them to be a bit more involved in the design of the service. Soft launches were thought to be very useful to manage sort of capacity and demand. There was comments on having central comms, but sort of locally adapted comms as well, so that each area has different offers, different providers, different routes that need to be considered. So having sort of a central comms that could be tailored to local needs was valued. There was also integration with the PAS advisor. PAS here refers to the patient advisory service that DWP sort of is leading on. If anything, the WorkWell coach model mirrored was inspired or got their sort of evidence from the PAS advisor sort of piece of work, which sort of spurred the work that we are seeing right now. But from an enabler perspective, that's where people thought that the integration with what was existing was quite key. Partnerships was seen as positive, especially with DWP and local authorities. The support that work coaches were also getting through a community of practice was also quite positive. Some of the challenges involved funding constraints, particularly in at the time not knowing how much funding they would get for what financial year. So there was an element of uncertainty there. There were contracting delays because of different governance structures. There was also complexities in capturing data because there wasn't like a central system that all the providers could use, which then led to sort of each local places having their own sort of CRM system, so to speak, to ensure that data is collected, which I think goes to the next point in terms of flowing that data for evaluation. There was a lot of conversation in terms of how do we get that data out, and then where does it need to go, and the IG behind it as well. So that was one of the sort of pain points in learning in terms of if some of that sort of understanding of the processes involved were clarified earlier on. Colleagues felt that could have sort of mitigated some of the risk in terms of how they built their data systems within their local infrastructures. The health and workspace can be quite busy. There is Connect to Work, there's Trailblazer, and there's that feeling that there can be overlaps, or how do we then ensure that it's a bit more seamless in that way? So some colleagues raised that as a concern. There was also external factors where organizational challenges limited what they could do within their own sort of mobilization. I'll just to give an illustration of what that data log looks like, for anyone interested in the methodological side, it's about sort of keeping track of what the durations are, number of attendees, and the anonymization that's been assisted by Copilot. So I think some of this analysis was assisted by AI, so that it ensures that the admin side of it was quite dealt with. The second part of the findings, I think, it's teams felt that there was inadequate early planning and scoping. And I think this was before like the model ICB blueprint was put in place, where the step one in terms of understanding local needs wasn't quite, it didn't quite mirror what was required as part of that strategic commissioning cycle. So colleagues felt like there wasn't enough planning and understanding what the data says, what the insights, what the research evidence suggests, and what's the involvement, sort of people involvement in terms of planning. So that was a bit missing in the program. There was a unclear central and local responsibilities, where confusion was quite widespread in terms of what's being done centrally and what's being done locally. There was also decision delays and disjointed communication. So some colleagues felt like even though things were approved at a local level, but there was another layer of approval that's needed, and that didn't help with mobilizing that and sort of managing relationships with different providers as well. Colleagues sort of flagged resource and capacity constraints because at the time the ICB was going through a restructuring and couldn't necessarily get the capacity for sort of program managers or a team to sort of manage that locally. So a lot of the people, a lot of the teams in the ICB, they were sort of doing it on top of their day job, so they felt like they could really contribute to really understand what the needs are in designing the pathway. GP engagement, I think it's sort of expanding on the Les point earlier on, but it does sort of, in terms of what we saw after the fact, there wasn't quite a way for to guarantee that GP referrals were coming in, and that was probably an issue where there needs to be a bit more clarity on how do we make sure that with the payments that have been issued, that there is a flow of sort of referrals coming in based on the criteria that's been set. So some of the program teams flagged like that's been a challenge in terms of getting them engaged and getting referrals in and help getting that sort of support from a primary care perspective. I think local partnerships and integrated working, that was sort of flagged or mentioned in the first analysis as well. That was quite positive. There's also some colleagues felt like having good news stories very early on helped in their implementation, because that's where the comms element comes into play, and it allows people the opportunity to share those early on. There are some additional reflections, but they're not necessarily big ones, and I'll probably just skim through this really quickly. I thought this would be an interesting way just to capture some of the tensions that that from both analysis that we could gather. So the first being funding timelines versus service expectations. There's always a need to mobilize something like yesterday, but not having funds transferred, and so things were put on hold because there wasn't like a clear process or a clear timeline, I suppose, in terms of getting the funding through so that services could be mobilized. Central versus local decision making, it was mentioned, I think, earlier on. Data requirements versus provider capacity. Here, it's understanding what's being needed from a national evaluation perspective, and understanding what capacity providers have to ensure that they collect the right data for evaluation. Because at the moment now, probably one of the challenges is data quality issues within the program that we could probably mitigate it if some of the considerations were put early on, and understanding if what the requirements are very early days. But I think in hindsight, we probably didn't know some of the challenges that local teams had with them, and these came into light quite early on, quite later on. Sorry. So I think it's just from an evaluation and data perspective, that's always been a sort of a bit of a tension in terms of how much is enough and how much do we actually need to build in that sort of local evaluation landscape, so that it doesn't burden the providers and it doesn't take away time that work coaches spend with patients in terms of actually supporting them with getting well and working. The fourth point on WorkWell offers versus other offers I mentioned in terms of how busy the space is. It's good that one of the priorities this year is to look at a no wrong front door approach. So hopefully that sort of streamlines some of the learning that we can see, and what that might look like from a local authority perspective. And I think Northumberland and Tyneside probably are a bit ahead in terms of thinking around integrating work and health as a single offer to the public, and making sure that some of the buzzwords around hiding the wiring and sort of making sure that people, it's easiest for the people being supported and not letting them be confused with the different offers in that space. Finally, probably more relevant for the commissioning teams around hands-on and hands-off commissioning. This probably came into light because of different teams had different ways of how they manage their relationships with providers, and hopefully with the new restructuring, that will clarify some of the responsibilities that commissioning teams need to take on board. Just sharing a few quotes. Won't go through all of them, but I think they're quite interesting just to see what the comments are in terms of not working in silos. The concept itself was positive. And then having that sweet spot in terms of what needs to be prescriptive at a program regional level and what can be flexibly done at a local level. And I suppose that's something we could probably start thinking around if you're moving towards neighborhood health, and what that might look like in terms of what people might want from a program regional perspective, as well as what could be realistically done at a local level. So my final slide here, I think, is just trying to bring everything together in terms of both data points, data collection, and considerations for future commissioning. And it's probably just reiterating some of the points mentioned earlier. But the first thing is strengthening early planning, scoping, and co-design of the offer with relevant stakeholders to understand local needs and provisions. This, I think, is understanding what the data says from a population health management, but at the same time, what the research evidence suggests, what's the evaluation plan as well, and what's the involvement of people within that space. Have we spoken to people, and what feedback do they have if a service is being designed from that perspective? So it's both the quantitative and qualitative element of trying to get a service up and running. Second point, I think, clarifying central versus local place-based roles up front to minimize confusion and reworking. And hopefully that comes into place with the new structure in May. And I think a lot of the conversations are moving towards clarifying that sort of roles and responsibilities and governance structures as well. The third, embed local system partnerships into program design to ensure sustainability and system integration. I think this mirrors a lot of the work that if a program is being done by a existing provider in the VCSC sector or the local authorities, it's worth thinking around how can that be linked, rather than trying to reinvent the wheel and start something from fresh. So it's understanding what's already out there and bringing it together into one sort of seamless space. Soft launches were seen as very positive to sort of allow rapid testing and learning. This is also to manage sort of capacity and demand. There's also the need to invest in workforce development and communities of practice, especially when a new program is up and running, because it's reflecting on the work that PAS advisors were involved in. So they've been doing it for a number of years now. So there's an element of learning there that when the community of practice for this program was set up, is to try and help shape that understanding and learning in terms of what they have experienced and how can the new work coaches help in their current work as well. Use incentives strategically to enable engagement in primary care and potentially tighten payment processes. I think this primarily came from the comment, like colleagues or the neighborhood health teams felt like there wasn't any guarantees that the practices would refer into the program. So there needs to be some element of how do we do that better in the future. Seventh point, clarifying evaluation requirements and align these with provider capability. And this is where I think what the data is needed, and it's probably a conversation with different leads to share the why, I suppose. Why are we collecting some of the data points? What impact can we see, and what's the plan with sort of different evaluation happening, whether it's regional, national, or even local, I suppose, in looking at different sort of provider capacity. Eighth point is about adapting the rollout of comms to local contexts and managing capacity. So comms was a huge discussion point in terms of thinking around what's being offered, not to confuse the public, and ensuring that people are clear on where to get the support, whether it's what route they might involve, especially at what the priority for this year is looking at self-referrals. And you know, like North Cumbria and Tees Valley, they've been sort of quite ahead in terms of self-referrals, and different areas are sort of starting it. And what that comms might look like probably is key in terms of not to confuse the people that we are supporting. Finally, capturing and share early impact and good news stories. And there's probably a mix to this one, because from a regional perspective, we are doing an evaluation, and there's a Newcastle University is helping with some of the data collection with that. And then there's the formal route in terms of capturing insights. But I think at a local level, some of the teams felt like having those sort of anecdotal evidence is a good start to know what's working before along to complement what was being done at the regional level from an evaluation perspective. So it's just thinking around how can we mix the two and not trying to bias what we're doing in terms of relying too much on the anecdotal evidence, and what can we do a bit more systematically and more robustly from an evaluation perspective. But good news stories are always good to kickstart and give people the confidence that things are working, and sort of help share learning across the system as well. My final slide is a thank you slide. If you have any questions, that's my email. That's also the research and evaluation team's email. So feel free to drop me or the team a message if you have any questions. But that's all from me. Over to you, Trace.
Thank you very much, Hamza. That was a really honest reflection on the lessons learned. And of course, great to hear that there are good news stories being shared as well, which obviously is always a positive. It's always great to hear about the value of sharing learning across our system and mobilizing any knowledge and experience gleaned along the way. So it's really great to hear. And also, it's obvious that you got some really good feedback from the focus groups, which is another great highlight of the importance of including end users in any production. Yes. And of course continuous development, continuous improvement along the way. We do have a couple of minutes left. Does anyone have any questions? Feel free to pop your camera on, pop your mic on, ask any questions. Hamdi's email was on there if you want to get in touch after the event. But oh, we have one, and it's Shona. Come in, Shona. Hi.
Hi, Shona.
Hi, so thank you. So I'm Shona Haining, I'm head of the Research and Evidence Evaluation team. Sorry, we changed our name. So I think, I mean, Hamdi, you know, I think that this is great work, and I think I'm really delighted that for Boost has been a platform to do this, and it's great there's been quite a mix of people on this. I think there's some really key learning points that really we need to just think about. How do we share that further? Like we were talking to the Commissioning Directorate yesterday. So some of these, there's some really generalizable things that as an ICB, because we're always learning and we always need to keep learning. So maybe just thinking about how we can use that going forward. Do we do a blog? Do we send a couple of these big key messages to some of the key teams, do some targeted stuff? But really appreciate you sharing this and Boost giving us a platform to do that. Thank you, Hamdi. Fantastic work as always.
Thanks, Shona, for that feedback. Yeah.
Thanks for that, Shona. Yeah, it is obviously really important that we share all this learning far and wide and get the message out there. Just on that, everybody who's attended today, you can share the recording with colleagues and wider networks. Victoria, would you like to come in?
Hey there. Yeah, thank you for that, Hamdi. That was absolutely fantastic, and it's great to see so many people on this. I'm a very junior OT, but my background was in employment law. I was an employment lawyer for 25 years, and working well, disability, that sort of thing was my a specialist area. And as an OT, my research that I did for my master's was on menopause and the occupational barriers to participation in the workplace that face menopausal women. And the way it was done produced some really interesting. I was inundated with applicants to be interviewed. And I just wondered whether there was any possibility of being involved as part of our trust to actually learn more about your work and help to disseminate it. And the missing link for me listening to your talk is involving local employers as well and making them realise that they are losing. I know presentations I used to give, they are losing millions due to long-term sick leave in their business productivity. That is their top priority. I know we see it through a completely different lens, but they all come together under, David Marmot's original research in 2010 and 2020 about social determinants of health, work being a huge part of that. So if I can get in touch, Hamdi, and talk within this forum about how we could involve employers to disseminate it, because I think for them it's a win-win if they have more people back at work as well.
Yeah. I think that's also part of the priority this year with the program, is to actually what can we do in the employer space in terms of supporting, and awareness is one of them, but I think it's also sort of what actual offers that occupational health offers that sort of employers have existingly, and at the same time SMEs is the focus as well. So but yeah, I definitely would be happy to link it up. If I'm not the right person, I'll link up with someone within the WorkWell team who might be better suited sort of to engage in that conversation as well. But we can definitely pick something up. So yeah.
Thank you. That would be amazing. I'd just like to continue my research as well, and I'd love to put it into this area.
Yeah.
Thank you so much.
No worries. Thank you for the question.
That's great. Thank you very much. Thanks to everyone who attended. You will receive an email link with an evaluation form. Any feedback that you can give us is always gratefully received. And if you have any ideas or suggestions for future Lunch and Learn topics, please do get in touch with info@boost. Their email address is available on the website. So thanks everyone for your time today. We have run out of time, so we will close there. Thank you. Goodbye.
Thank you, everyone.
Thank you.